here, and as mentioned already, again, is repeat what are the 5 factors that regulates the blood pressure, which is blood volume, heart rate, stroke volume, peripheral resistance, and blood viscosity. Okay, um, this is it just to show you what cardiac output is. That's all that is. Now, what is cardiac output? Cardiac output is equals to okay, heart rate times stroke volume. Cardiac output is equals to heart rate times stroke volume. And you can see here is that in the cardiac output, heart rate typically is about 75 beats per minute, and stroke volume is about 75 milliliter per beat, right? Sometimes 80. And you multiply that out, for example, cardiac output is about 5 liters per minute. Now, of course, when you exercise, your heart rate will increase, your cardiac output will be increased. And cardiac output will be increased, it can go up to 30 liters per minute. That's telling you that your heart typically is putting out the volumes of blood that you have, 5 liters in 1 minute. I mean the blood that flows from the right atrium to the right ventricle to the lung, back to the left atrium, to the left ventricles, to the aorta, different distributing arteries, down to the femoral arteries, to the anterior tubular artery, come back to the veins, femoral vein, the iliac, external iliac vein, inferior vena cava, back to atrium. You know, if you have a small submarine that flows through all these pathways, you're coming back to the heart in 1 minute. That's how fast the blood flow is. In some places during the exercise, cardiac output might go up to 30 liters per minute. So the difference is known as cardiac reserve. Now, you cannot maintain high heart rate to maintain the cardiac output, right? So an athlete, however, the heart rate cannot be continuously high because that would lead to a heart attack. So what oftentimes is that the cardiac output is increased is because the stroke volume is increased, right? We talk about how the end-diastolic volume, right, is the volumes of blood in the ventricle is about 160 millimeters of mercury, roughly, right? If the stroke volume is 80 millimeters of mercury, 80 milliliter of blood, right? So then the end systolic volume, not stroke volume, this is stroke volume. The end systolic is 80, right? So in this case, you see is that the efficiency of the heart rate is 50%. But an athlete, you know, people thought that Lance Armstrong, before he was doping, you know, give himself more red blood cell and blood exchange, or even inject himself with EPO. He might put out 100. His stroke volume is 120 ml. Okay, so the end systolic volume remaining is only 40 ml. So you can see that 120 ml over 160 ml, what is that efficiency? That's like 120 divided by 160 is about 75%. So some athlete can go up to 80%. So that per contraction, there's more blood leave than you and I. Okay. All right, so here's cardiac output and cardiac reserve. Cardiac output is the amount of blood pumped by each ventricle 1 minute, right? Is product of the heart rate times stroke volume. Heart rate is not stroke volume. Cardiac reserve is the difference between the resting and maximum cardiac output. That could be up to 30 ml, 30 liter per minute. All right. Now, here are three important factors that regulate the stroke volume. Okay? Remember, stroke volume is the volumes of blood that leaves the heart. We've talked about already contractility. Contractility is the strength of the contraction. If you increase this contractility, the stroke volume will increase. Okay? And one way, what are two ways that you know, looking at the frog electrophysiology, for example, right? And you saw that contraction, and this versus this increases the amplitude, okay? So the one way is that more calcium. So calcium regulates contractility as well as epinephrine. Okay? All right, so that's finished with contractility. The higher the contractility, the higher stroke volume. Another factor is known as preload. If you increase the preload, you're going to increase the stroke volume. So preload is venous return. All right, and so what this means is that, you know, if you recall, the skeletal muscle is subject to length tension relationship, right? That depends on the sarcomere. If the sarcomere is too short, it's not going to contract very well. If the sarcomere is too long, it's not going to contract very well. There's an optimal sarcomere length to have the maximum contraction, right? Now, and that is because of the striation, you know, because of this constraint of actins and myosin sliding past each other. Well, it turns out that cardiac muscle also has striation and is also subject to length tension relationship. And in fact, the heart contracts strongest when it's filled with blood. When it's not filled with blood, the sarcomere length is suboptimal. But when there is blood coming back, it stretches it out. Then it's going to contract very well. Okay, so depends on the volumes of blood that return. If there's sufficient blood coming back to the heart, it's going to contract well. So increases preload, increases the stroke volume, right? So in fact, what you could do is that you can give people more fluid, if you will. Then there's more volume coming back, the heart is going to contract. More blood coming out per contraction. Okay, so that is not so much significant than to think of it the opposite, then it makes more sense. So let's say that their preload is decreased. Okay, that means the venous return is decreased. When in this case, what happened? Well, because you have blood loss, for example, right? So your normal 5 liters of blood now, when you have 4 liters of blood. So less blood coming back to the heart, then the stroke volume will decrease. It's going to contract weakly, it's going to decrease. And so your blood pressure will go down. Okay? That's it. So in fact, there's a general rule that they ask this in all nursing exam is what is the Frank-Starling law of the heart? Law of the heart. Okay. Now the Frank-Starling law of the heart it really depends on the preload. Right? It's not. It doesn't depend on contractility. It doesn't depend on contractility. It's on preload. What is afterload? We're going to talk about a little bit. But really, what you should think about is this. In the Frank-Starling law of the heart is another way for you and me to think about it is this, and that is quote unquote, the heart will pump the amount of blood it receives. That's another way to think of it. So if there is more blood, more blood goes in, more blood goes out. Right? Less blood goes in, less blood goes out. That's the bottom line. That's the Frank-Starling laws of the heart. Is that the heart will pump the amount of blood it's received. Okay, if it comes in, more comes in, more goes out. Less comes in, more comes out, and all that is preload. So the Frank-Starling of the heart, it depends on the preload, not contractility. Right? What is afterload? Afterload is that blood pressure. So that if the afterload is increased, the stroke volume will decrease. Okay? And this is the diastolic pressure, if you will. Okay? If the diastolic pressure, remember, we talk about the diastolic pressure, someone who is normal 80 millimeters of mercury, then the intraventricular pressure only have to generate about 81 so that the aortic septal valve will open up. But if someone has chronic hypertension, the diastolic pressure is 90 millimeters of mercury. The intraventricular pressure has to be 91 to open up that. So if you increases the afterload, the heart, the blood that leaves the heart is not as high. So stroke volume would decrease. All right, so here shows you the Frank-Starling law of the heart. Is say mechanistically is affected the preload, the degree of stretching, right? Critical for it. So slow heart rate, exercise increases venous return, increases the stroke volume. So basically, you exercise, more blood coming back to the heart, more blood coming back to the heart, it's going to eject more. And if it's blood loss, there's going to be less blood coming back to the heart, less stroke volume comes out, decreases stroke volume. Here's it shows you preload. It's the stretchability of the cardiac myocyte to reaches to the optical length, and the afterload is the back pressure that you see here. Okay, if the afterload increase, the volumes of blood out decrease. Okay, and here, by the way, you may or may not appreciate this. Let me ask you a question. If there is a left-hand side heart failure, where would you have the edema? Systemically or in the lung? So would you get pulmonary edema? Let me do a poll here. Let me do a poll and see what do you guys think? Okay. Multiple choice. Okay. If there is a left hand side heart failure, would you get systemic edema, or would you get pulmonary? Okay, I'm going to start this poll. All right, tell me. So what happened to the other 20 people? Sleeping? Take a guess. Come on, 12 people. I need it. Take a guess. We have 27 people. Half of 27, 14. I need a, I need to have majority. 6 people, make a guess. 4 people, take a guess. All right, here's the response. I wonder if you can see the response. Okay, I'm going to stop the polling here. You know, actually, you're right. They're going to be, so half of you says that it is pulmonary edema, and that's the correct answer. So there's 13 of you are the A and the B student, right? The other one is a C, and the one that's not responding, well, they're hopeless. I don't know. I can't help you if you're not participating. It's true because, look, the left-hand side pumps the blood that is received, right? When blood goes in, blood goes out. Blood goes in, blood goes out. Blood goes in, blood go out. Now, if this side fell, blood trying to come back in, but it's not, it can't go anywhere. So there's gonna back up, back up. So left-hand side heart failure, pulmonary edema. Right-hand side heart failure, right? Right-hand side, blood go in, blood go back in, but it can't pump anymore. It cannot eject, it's gonna back up. In fact, that's the term, back up. There's a back up. You might see that the distended neck, the jugular vein might get popped up, for example. And this thing all goes back into the liver. The liver is going to get really big, and so forth. Okay, so right-hand side heart failure will lead to systemic edema, whereas left-hand side is usually known as pulmonary edema. And in pulmonary edema, if you get the lot of fluids is in the lung, that could also lead to a lot of fluids leaking from the blood vessel, pulmonary artery, that could also interfere with the gases exchange. All right, so make sure you know the difference between pulmonary and edema versus systemic edema. Okay. What are some of the other intrinsic factors that could, extrinsic, that can regulate the contractility, and that is, you know, increases contractility due to increased contractility, increases stroke volume. I would say sympathetic nerve is the most important one, right? Calcium and some drug as well. The factor that could decreases contractility is calcium channel blocker, the ABCD. Increases contractility, decreases contractility, decreases stroke volume, decreases blood pressure, as well as acidosis, or increases extracellular potassium. So when you see that in the frog electrophysiology, if you have too much potassium, we call it hyperkalemia. In fact, if you kill someone in Texas, and as part of the capital punishment, they might give you a bolus injections of potassium. Yeah. A bolus injections of potassium. So you have hyperkalemia. So in essence, too much potassium, your heart cannot repolarize. If your heart cannot repolarize, it cannot contract, and you stop. Okay. blood potassium level typically is about 5 milligram per deciliter, or 5, we call this. Now, intracellularly, by the way, um, in the case of red blood cell, uh, there's a lot of potassium inside, right? And so I might give you a clue is that in a mismatch reaction, so let's say if your blood type is A, and they give you uh, blood type B, right? You have antibody here that can react to this, and it leads to lysis, hemolysis, and all that potassium inside will spew out, right? And so you can have hyperkalemia. Hyperkalemia, heart rate will decrease. Right? So you can say here's one cases where hyperkalemia occurred due to destructions of red blood cells. Okay. And what is the root cause of that? In this case is mismatch. You're not giving the person the right blood type. Alrighty. And how does norepinephrine or epinephrine work in contractility? Mechanistically, it works to intracellular signaling via the second AMP level. I don't really, you really don't need to know this, but here is the key. Okay, one of the important things that we talked about earlier, how in the skeletal muscle contraction and summation, right? Summation is due to increases the frequency of stimulation, so that you don't allow sufficient calcium to be put back into the sarcoplexus reticulum, right? And so in this case, what you see is that this is cardiac myocyte. And what the epinephrine does is that it increases the contractility by allows us more calciums to exit. Okay? And more calcium you exit, you have more a greater the strength of contractility, if you will. That's all that is. I probably won't ask you this in the exam. Okay? Again, 5-factor regulating the blood pressure, regulate heart rate. Factor that is affecting the heart rate time is known as chronotropic. Okay? Chrono means time. Positive epinephrine is the key, right? Caffeine, of course, you already know that. Too much caffeine, your heart rate will increase. Nicotine and thyroid hormone, which increases the beta adrenergic receptor. But besides nicotines and thyroid, these two you need to know: epinephrine and caffeine, which increases the heart rate, which you already know. And negative chronotropic, we saw it as part of the for electrophysiology, the compounds called digoxins, if you will, or digoxin here from or digitalis, if you will, that comes from the foxglove plant, decreases the heart rate, just like beta blocker decreases the heart rate. Okay. This is digoxin. Heart rate, similarly, mechanistically, you don't need to know that. Sympathetic, of course, increases the heart rate. Parasympathetic decrease. We talk about that. And I think I'm pretty much finished. Lastly, the atrial brain bridge reflex is a reflex that is initiated by if you have more venous return, right? In fact, causes the SA node to uh, fire, undergo a rapid depolarization to increases the heart rate. So the atrial vein bridge reflex is really just saying that if you have more SA node, more blood return stimulates the SA node, right? And as the SA node is depolarized faster, you're going to have an increases heart rate. That's it. Okay. Chemical regulation, some ions. We talk about ionotropic factor. Calcium and potassium is very important. Hyperkalemia or hypercalcemia. And let's say, lastly, is this one. Okay. Now, this is the summations of everything that we talk about, and that is particularly if you have low blood pressure. So you can start here, hemorrhaging, right? Now, what is there? There's a short-term effect and there's a long-term effect. In trying to, homeostatic mechanism is to increase your blood pressure, right? Low blood pressure, a lot of tissue, particularly the heart itself, rely on the coronary circulation for the blood. And if their blood pressure is low, it's not going to get its oxygen, its nutrient, its need, it's going to die. But a lot of tissue will die. So this green arrow is stimulus, this red arrow is inhibit. So you can see here is that if the blood pressure is low, sympathetic nervous system is activated, right? From the adrenal medulla, which is controlled by the by the medulla oblongata, for example. The sympathetic nervous system has two functions: increases contractility to increase the stroke volume, but sympathetic also increases the heart rate, right? So those are the two factors that increases the blood pressure, and so that your cardiac output will be increased. If the blood pressure is low, you're not going to have sufficient oxygen. Cardiac output will be decreased because the stroke volume comes out here slow. At the same time, you will see is that the kidney is trying to participate by increases the blood volume. How does it increases blood volume? Well, it can act it through the renin, which is convert angiotensinogen to angiotensin 1, and then via ACE convert angiotensin 1 to angiotensin 2, which angiotensin 2 stimulate the adrenal cortex to put out aldosterone, and aldosterone will stimulate the kidney to take back sodium and water. Okay, so renal activity will increase. If you have more sodium, more water, the blood volume will increase. Venous return hopefully will increase. Okay, venous returns increase. In diastolic volume increase. In diastolic increase, stroke volume will increase. On the other hand, what you see is that if the blood volume is low, the blood pressure is low, the venous return is going to be slow. Okay, venous return itself in diastolic would decrease. In diastolic decrease, stroke volume will decrease, and the attempt is trying to bring it up. Okay. What else do we need? So this is sort of like outline out what we discussed today. I'm going to just end it there. Congestive heart failure, I would say that there are many causes: blockage of coronary artery, constant high blood pressure, myocardial infarct, heart attack, dilated cardiomyopathy. All of this I'm going to discuss in my pathophysiology course, but a congestive heart failure typically leads to a decreases in the stroke volume. Okay. All right, I'm going to stop there.